Welcome to Module 3. This is an overview of exercise for non-dialysis chronic kidney diseases and end-stage kidney diseases. This module was developed and is presented by Danielle Kirkman from Virginia Commonwealth University, Mara McAdams from New York University, Ken Wilund from the University of Illinois Urbana-Champaign, and Paul Bennett, the University of South Australia. In this module, we'll provide an overview of the current evidence pertaining to the effects of exercise in patients with mild to moderate chronic kidney disease that do not yet require renal replacement therapy, patients who are currently receiving hemodialysis or peritoneal dialysis, and in kidney transplant recipients. We will provide an overview of the benefits of exercise, but we'll also address the limitations in the current data. We will start this module by focusing on patients with chronic kidney diseases that do not yet require renal replacement therapy. In this section, we'll start by providing a brief overview of physical activity and cardiorespiratory fitness levels in patients with chronic kidney disease as a rationale for exercise intervention. We will then cover the current evidence on exercise for health-related outcomes in this cohort of patients, and we'll finish by highlighting the areas that require further evidence. There is now conclusive evidence demonstrating that habitual physical activity levels are markedly reduced in patients with chronic kidney disease. Compared to their age-matched counterparts from the general population, patients with chronic kidney disease report higher levels of sedentary behavior, and fewer of these patients meet the current physical activity recommendations. It is therefore unsurprising that these patients present with severe reductions in cardiorespiratory fitness, reported as maximal oxygen uptake or VO2 peak. This is evident even in the early stages of the disease and in patients without overt comorbidities such as cardiovascular disease. These reductions in physical activity and cardiorespiratory fitness are extremely important as they have been shown to be independent predictors of comorbid conditions and mortality. Therefore, increasing physical activity levels and/or introducing structured exercise training holds promise as an interventional approach to improve health-related outcomes in these patients. So, what is the available evidence to support exercise intervention, and how might this inform how we prescribe exercise at this stage of kidney disease? We will start with data relating to exercise to improve cardiorespiratory fitness and physical function. Overall, studies have shown that aerobic exercise of moderate to vigorous intensity leads to improvements in cardiorespiratory fitness, reported as VO2 peak, which is the gold standard measure of fitness. In terms of physical function, when looking at meta-analyses data that have taken all randomized controlled studies into consideration, aerobic, resistance, and balance exercises all seem to have a positive benefit on physical function. These gains appear to be greatest in interventions that combine both aerobic and resistance exercises. This is the same for muscular strength, with greatest improvements being observed in combined interventions. However, despite the observed benefits, it does appear that compared to matched individuals from the general population, patients with chronic kidney disease may have some attenuated adaptations to exercise training. The data on the top panel are from a randomized controlled trial of stage 3 to 4 chronic kidney disease. Those who were randomized to an exercise group completed 12 weeks of supervised moderate to vigorous aerobic training for 45 minutes 3 times a week. Even though exercise improved VO2 peak, the increase in cardiorespiratory fitness falls below a clinically meaningful difference, and values still remain below age-predicted normative values. This trend appears to be replicated in another well-designed randomized controlled trial that compared aerobic exercise alone with a group that completed combined aerobic and resistance exercise. As you can see from the figure in the bottom panel, there were no significant increases in cardiorespiratory fitness in either aerobic or the combined training group. The second area of health-related outcomes that we'll cover relate to cardiovascular disease. Patients with chronic kidney disease are more likely to die from cardiovascular disease than progress to end-stage renal diseases. Therefore, cardiovascular disease prevention is a cornerstone of treatment in early stages of the disease. Aerobic exercise is touted as a powerful stimulus to improve cardiovascular health and is routinely implemented in other disease populations to reduce cardiovascular disease risk. Here we present a randomized control trial that enrolled patients before the development of overt cardiovascular disease. The study investigated the effects of aerobic, moderate to vigorous intensity exercise on vascular endothelial function and microvascular function. The study showed that exercise maintained vascular endothelial function compared to a decline that was observed over the 12 weeks in a control group. The exercise intervention also improves skin blood flow, a marker of microvascular function that mirrors coronary microvascular function. These findings have important implications for cardiovascular disease prevention, as endothelial dysfunction and microvascular dysfunction are initial physiological events in the pathogenesis of cardiovascular disease. In addition to the vascular benefits, aerobic exercise also appears to have a positive effect on cardiac function. Exercise of this modality has been shown to preserve cardiac systolic function and improve cardiac diastolic function. With regards to blood pressure, the data still remain inconclusive. A meta-analysis has shown that exercise does not move the needle with blood pressure, whilst other studies have reported that aerobic exercise substantially reduces the number of blood pressure medications taken by patients. Exercise does not seem to be effective at reducing or changing blood lipids or altering arterial stiffness. It is speculated that structural changes and calcification of the vasculature appear harder to reverse, and this highlights the importance of prevention in this patient population. Finally, what do we know about the effects of exercise for metabolic health? We'll start by covering the effects of exercise on body composition. Patients with chronic kidney disease are prescribed a low-protein diet to preserve kidney function. It has been speculated that this low-protein intake may be a partial contributor to a reduction in lean body mass that is characteristic of the disease. An early study showed that adding resistance training to the prescription of this low-protein diet may mitigate the declines observed in muscle structure and function. The study showed that compared to a low-protein diet alone, those who added high-intensity resistance training to their routine 3 days a week over a period of 12 weeks saw significant improvements in muscle fiber cross-sectional area, a surrogate result for improvements in muscle composition. With regards to adipose tissue, a randomized controlled trial has shown that aerobic exercise of moderate intensity seems to be effective at reducing visceral fat. This finding shows promise for the effects of aerobic exercise in reducing adipose tissue. Overall, in the non-dialysis CKD population, the effects of exercise on metabolic health have been less explored. The limited data do show promise for aerobic exercise at reducing waist circumference and visceral fat mass, while aerobic and resistance training show improvements in lean mass quality. The increases in lean mass seem to be more pronounced with resistance training or combined aerobic and resistance training interventions. The effects of exercise on glycemia and insulin sensitivity are largely unknown. This highlights a noteworthy gap in the knowledge, as poor glucose control is a large contributor to declines in kidney function. Therefore, this marks an important area for future research in the field. Exercise appears to be safe and beneficial for patients with non-dialysis chronic kidney disease. We do not need to wait for further evidence before we implement exercise as part of routine care for these patients. However, there are still some current gaps in the knowledge, and there are some certain areas that would benefit with further research. The first of these areas pertains to the effects of exercise training to improve kidney function and slow the progression of kidney disease. There's certainly a lack of randomized controlled trials in this area, and certainly earlier controversies and concerns propose that exercise may actually be detrimental to kidney function due to a shunting of blood flow away from the kidney. However, when we examine exercise training studies that report a marker of kidney health, exercise does not seem to appear to be harmful to kidney function. There appears to be a lack of randomized controlled trials investigating the effects of exercise training on hard clinical outcomes such as hospitalization and mortality. However, whilst there is a lack of experimental data in this area, there is still strong epidemiological data in favor of increasing physical activity levels and increasing exercise intervention. While there have been advancements in the development of clinical guidelines for exercise prescription in non-dialysis patients, we still need more evidence to delineate specific fit principles that will help us personalize the precision of exercise prescription. Finally, compared to age-matched healthy individuals, patients with CKD appear to have some attenuated chronic physiological responses to exercise training. Therefore, future research should investigate synergistic interventions that are aimed at enhancing training adaptations in this patient population.
Hello, my name is Ken Wilund. I'm a professor in the Department of Kinesiology and Community Health at the University of Illinois, and I'll be presenting this section on exercise in hemodialysis patients. By way of an outline, some of the topics we'll be hitting today include a review of some of the typical types of exercise programs that have been done in hemodialysis patients. I'm going to be discussing some of the demonstrated benefits of exercise, as well as some of the limitations in the data on exercise in hemodialysis patients. I'll also be discussing some of the highlights from some recent large clinical trials done in this area, as well as discussing some of the next steps for exercise in this population. I'd first like to start off by discussing some of the options for exercise in hemodialysis patients. And suffice it to say that the most traditional exercise programs for dialysis patients have involved one of just several different types of exercise, and they can be broken down into what we call interdialytic exercise. So that's anything that's done during dialysis, or out of clinic exercise, which is anything done outside of the clinic. And with both of these modalities, we've had programs that included mostly endurance training or mostly resistance training, or sometimes a combination of both. But most of the data that you see in the literature of exercise in dialysis patients, hemodialysis patients, is from interdialytic cycling. Probably 75 to 80% of the studies that have been done have involved interdialytic cycling, which is essentially sticking a bike in front of patients during their hemodialysis sessions. And the reason this has been done so often is because it's a relatively efficient form of exercise. We know where our patients are going to be 3 days a week. They're going to be at the clinic. And so we bring them a bike, and we have this kind of relatively captive audience. So we can bring the bike to them and have them cycle during their dialysis sessions. So it's not something that takes up a lot of their time because they're at the clinic anyway. There's also been a number of studies in more recent years where we've, as the research community has done some interdialytic resistance training interventions. This involves using some combination of dumbbells or ankle weights or resistance bands or balls to perform different types of exercise resistance training during dialysis. There's been several programs published on using at-home walking programs. There's also been a few out-of-center resistance training studies, and as well as some other sort of novel exercise physical activity type programs, such as Zumba or laughter yoga or lifestyle physical activity programs. More recently, some virtual reality and gaming programs. So the bottom line is there's been a lot of different strategies that have been tried to get patients moving more in different ways, but the primary type of exercise has been prescribed to date is interdialytic cycling with a little bit of resistance training mixed in. So next I want to talk about some of the pros and cons of different types of exercise for dialysis patients. First, with intradialytic exercise, one of the reasons that it's prescribed so frequently is because it's very efficient, and you have this captive audience. You know the patients are going to be at the clinic 3 days a week. Stick a bike in front of them, for instance, and trying to get them to pedal during their sessions is relatively easy, at least in theory. But some of the concerns with intradialytic exercise is that because they are in a chair or in a dialysis bed in some places, they have limited mobility. But it does make cycling the most feasible type of exercise. Resistance training is possible, but it presents challenges, especially because of this limited mobility. One thing in particular is that while you can do lower body resistance exercise relatively easily, upper body exercises are more challenging because the vascular access is usually in an arm that can't be moved during their session, so only one-armed activities are usually possible. But for exercise not during dialysis, in theory, the options are unlimited. They can do essentially just what a person that's not on dialysis can do because it's being performed on a non-dialysis day. So that's the benefits, but there are concerns with compliance with exercise not during dialysis. The patients often don't have access to either gyms or proper exercise equipment at home. Motivation is low because they're tired. There's a lot of fatigue, and that prevents them from exercising more. And exercise usually isn't supervised like it can be during dialysis. So next I want to talk a little bit about the scientific literature and what it says about really how well exercise seems to work in hemodialysis patients. There's been a number of systematic reviews and meta-analyses that have been done on this topic, whether you're talking about all stages of chronic kidney disease, which includes pre-dialysis, dialysis, and transplant recipients, or just a lot of reviews that have focused specifically on dialysis patients themselves. Now, this is not an exhaustive list. There's been dozens of these reviews that have been published, but when you read them, the data seems to be pretty impressive. Regardless of the volume, the intensity, the timing, or the mode of exercise, exercise seems to improve just about everything. Aerobic capacity, physical function, strength, body composition all improve. Cardiovascular function, by and large, seems to improve in most studies. There have been some unique benefits such as solute clearance, removal of phosphorus and potassium in particular, which build up in dialysis patients. But when we exercise, especially during dialysis, you're perfusing the skeletal muscle more, so these solutes appear to get removed at a higher rate than they normally would have. Patient-reported outcomes, including cramping, fatigue, restless legs, and other metrics that impact quality of life, all seem to improve. But I do want to mention that there are a lot of caveats in the literature, and there's some concerns in the data that I do want to highlight. So what are some of these caveats, concerns with the data? Well, first, despite what I just said on the last slide about his pretty robust benefits and a lot of the systematic reviews and meta-analyses, when you look at the individual studies, the large clinical trials in particular, the benefits that you see are often relatively modest or inconsistent between different studies. Also, the volume and intensity of the program, the exercise program, is usually rather low, well below physical activity recommendations of 30 minutes most days of the week. The exercise prescription for dialysis patients are usually provided is much lower than this, so they're not meeting physical activity recommendations. And exercise prescriptions I describe them as usually rather simple, mundane, or boring for most patients because they're mandated types of exercise, like either just walking or cycling or resistance training. They're not enjoyable activities for most patients. And as a result, participation is often pretty low. In most studies, you'll see about 10, 20, maybe if you're lucky, 30% of patients in any particular dialysis clinic may participate. And the dropout rates, despite these modest subscriptions, are relatively high. So usually around 30% of patients will drop out in a 6-month period. And also compliance and adherence with the prescribed activities are low. And really another important factor is that the activity is not sustained once the research study ends. So the patients will exercise during the program, they'll complete the program, but once the program ends, they stop exercising. and that's obviously concerning. So to highlight some of the benefits and limitations of exercise in hemodialysis patients, I want to briefly discuss some results from 4 trials that are recently been published in the literature. And I think I could have picked out a number of different studies, but these 4 kind of provide some sort of overview of the state of exercise in hemodialysis patients. So the first of these studies that I want to highlight is called the Exercise Introduction to Enhanced Performance in Dialysis Trial, or EXCITE trial is the acronym. So the objective of this is pretty straightforward. It is to investigate whether a home-based exercise program improved fitness and quality of life in hemodialysis patients. The design, it was a multi-center randomized clinical trial where they recruited 296 patients to participate in the study. So it's one of the largest studies ever conducted in dialysis patients and largest exercise studies. Include an exercise group that was prescribed walking at home that was paced by a metronome, and then a control group that got usual care. But I want to draw your attention to the consort diagram here on the left because it's very informative. So these 13 units had 714 dialysis patients they could potentially recruit. But a number of them were not eligible for the study for a variety of reasons, which is typical. But of the roughly 500 patients that were eligible, 180 they refused to participate at the outset. So of those that were eligible, they were able to randomize just about 300, 151 into an exercise group, 145 into the control group. What's informative, what I mentioned earlier, is that of these 151 in the exercise group, only 104 finished the 6-month intervention. So roughly a third dropped out. And this is a pretty standard dropout rate. What really highlights is just how difficult it is to keep dialysis patients in a exercise trial for any length of time because of all the physical limitations and other medical and health problems that they have. A lot of patients drop out of these trials. So in this slide, I'd like to provide a summary of the training protocol that was used in this study. Now there's a lot of numbers on this table. You can walk through this at your leisure, but I've kind of summarized it over here on the right. So the prescription in this trial was walking program 3 days a week on non-dialysis days. The participants were asked to walk 20 minutes per day, which is broken down into 2 10-minute walking sessions. But if you do this simple math, 3 days a week times 20 minutes a day, you get a total prescription of 60 minutes per week of walking. That's not a lot of exercise. Now, they did this for 24 weeks, but if you just ask yourself the simple question, how does this compare to traditional physical activity recommendations of 30 minutes most days of the week? It's somewhere between a half and a third of the prescription we provide to most populations. So this in and of itself is somewhat concerning. Again, I mentioned before, exercise prescriptions, the volume intensity of exercise that's often prescribed for this population is rather low. And despite this, compliance adherence with activity prescription is relatively low. So in this slide, I want to highlight some of the benefits that we're seeing from this program. So as I mentioned, the exercise prescription was relatively modest, but the encouraging part is that exercise did seem to improve physical function, and it did so in a dose-dependent manner. And I'll walk you through what that means on this slide. So they measure physical performance or physical function 2 different ways, using a 6-minute walk test, how far can you walk in 6 minutes, as well as what's called the 5-time sit to stand test. So this is how long does it take you if you sit down in a chair and stand up, and sit back down and stand up, how long does it take you to do 5 of those sit to stand tests? So in the 6-minute walk test in the control group, there was no improvement in their performance. But in the active arm, the arm that did the exercise 3 days a week, there's a 39-meter improvement in their performance on the test. So that was statistically significant improvement. So that's nice. In the 5-time sit to stand test, which is a measure of lower body leg strength, control group, there was a slight improvement that wasn't statistically significant, but in the exercise group, there was an improvement that was indeed statistically significant. So they improved their performance on the sit to stand test and the 6-minute walking test. And importantly, I said they did so. The benefits improvements were in a dose-dependent manner. So in those that compared to the control arm and those that were in the active arm, but they didn't adhere well to the exercise prescription, they saw an improvement. But those who adhered really well to the walking program, they had a greater improvement. Same thing with the sit-stand test. Compared to the control group, those who were in the exercise group but didn't adhere very well still saw an improvement, but those that adhered well saw a much greater improvement. So this is a nice finding. Unfortunately, they also had a number of different secondary outcomes they measured, and not all those improved, including quality of life. And this is going to be a consistent finding in the literature that despite prescribing exercise a number of different ways, whether it's interdollic exercise, out of clinic exercise, quality of life doesn't seem to improve in this population in response to most exercise prescriptions. So the next trial that I want to briefly describe is a trial called Cycle HD. This was a randomized controlled trial to investigate the effects of interdialytic cycling on left ventricular mass. So this was another really large study. It was conducted in the UK a couple of years ago. They recruited 130 dialysis patients and from 3 different dialysis units, and they randomized them to one of 2 groups: a group that had standard care plus interdialytic cycling for 6 months versus standard care without the interdialytic cycling for 6 months. So basically a control group. And the primary outcome in this trial was left ventricular mass, the change in left ventricular mass from baseline between the groups, measured using cardiac MRI. And I'm not going to go into a lot of the details of the study. It was a pretty standard program. They cycled 3 days a week for about 30 to 40 minutes or so. And the good news in the study is that the interdialytic cycling did indeed lead to a reduction in left ventricular mass. And this is a really important finding because left ventricular hypertrophy is a big problem in this population. So on average, their LV mass went down by a little more than 11 grams in the 6-month period. Interdialytic cycling also improved with pulse wave velocity, which is a measure of arterial stiffness. So their arteries weren't as stiff. This was a secondary outcome, but nevertheless, it's relatively important. Other highlights from the study is that the participants completed almost 72% of their exercise sessions and maintained the exercise intensity. So the adherence with the prescription was much higher than you see in a lot of other studies. One of the reasons I think that was because this trial would a lot of exercise interventions in dialysis patients, including most interdialytic exercise interventions, are run by nurses. This one was actually run by exercise specialists that helped maintain compliance with the program. Another little bullet point here I want to mention is it says 51 SAEs. Those are significant adverse events. That 51 adverse events were reported during the study, but none were assessed as related to the intervention. And this really highlights the fact that despite the fact you're working with this really sick population, there's very little evidence of adverse events from exercise during dialysis. So exercise is safe. And that's a consistent finding in the literature. That's really nice. So the conclusion from this study is that a 6-month program of interdialytic cycling significantly improved LV mass, had other benefits as well. It's safe, deliverable, and well tolerated in a clinic. But I do want to mention, so while this certainly had a lot of important benefits of the study, I did want to mention a couple of the other outcomes from the study. Again, quality of life was not improved in the exercise group compared to the standard care group. And also physical function did not improve. There were trends for improvement in physical function, but it didn't improve. So their primary outcome, LV mass, improved. That's fantastic. But quality of life and physical function did not improve. And again, I talk about the inconsistencies in the literature, and this comes up over and over. So the third study that I want to highlight is another large randomized clinical trial assessing the effects of exercise, interdialytic exercise on quality of life. I've already mentioned that in a couple of these studies, the quality of life did not improve, but the quality of life in those previous studies I mentioned, those were secondary outcomes. This was a trial that was specifically designed to see if intradollic cycling improved quality of life for this population. Again, out of the UK, 12 different dialysis clinics, they randomized 116 patients to a control group versus 127 that got randomized to interdialytic exercise. Primary outcome, quality of life, and again, without going into details, it was a pretty standard exercise prescription, 30 to 40 minutes or so of exercise 3 days a week, cycling during dialysis. Primary outcome, quality of life, did not improve in the exercise group compared to the control group. There was a trend for an improvement in quality of life. The p-value 0.055, so not quite less than 0.05, which is the standard metric for determining statistical significance. But it's still, regardless of, even if you are not concerned with the p-value being less than 0.05 or being in this case a little more than 0.05, it's still, you did not see a robust improvement in quality of life, if anything. But other outcomes too, physiological impairment. So they measured peak oxygen uptake. There were no improvements in the intervention group compared to the control group. Compliance and adherence of the exercise protocol, despite being just 3 days a week for 30 minutes or so, was very low. Adherence 18%, compliance 47%. The primary difference here versus the cycle trial that we just talked about was that this intervention was run by nurses who have other things to do. It's not that they're not capable, but they're very busy. So when you try to run an exercise program with the nurses as opposed to dedicated exercise professionals that are there for that purpose and that purpose only, you tend to get lower adherence and compliance to the exercise prescription. Some of the benefits of that we're seeing in this trial, that again, very few adverse events. Control group had 56, exercise group 69, no significant difference. Again, showing that interdialytic cycling is safe, but how effective is it? Probably marginally effective. Another interesting outcome is for the study, the cost of intervention they assessed to be about $600 US per participant per year. So if we get the interdialytic cycling to work, what this study shows is that it's not that expensive to have somebody conducting a study like this, but again, we still want to see more robust benefits than we saw in this trial. So the next study I want to talk about is a smaller trial that has assessed the acute effects of intradialytic cycling on myocardial stunning. If you're not familiar with this term, myocardial stunning is essentially a decline in cardiovascular functions caused by ischemia that results from significant drops in blood pressure that occur during dialysis when you remove excess fluid by ultrafiltration. So myocardial study in this trial was assessed in 19 patients on 2 occasions. So it was a small trial, but they assessed myocardial stunning on a control day, so a day when they got dialysis with no exercise, versus on a day when they got dialysis with interdialytic cycling for about 30 to 60 minutes. So the primary outcome in this study was that the number of stunned segments, which is measured by echocardiogram as regional wall motion abnormalities, that's what the RWMA stands for, this was reduced at the end of dialysis on the day they exercised versus the day they did not exercise, as you can see in the graph here. And my take on this data is that one is it's very exciting, but there are some limitations. There's a small study, 19 people, acute exercise, it wasn't exercise training, so it needs some confirmation in a larger, longer trial. And this is a study that is indeed in progress. But there are some really important findings, the positive, potential benefits here, because it's a potential novel benefit of intradialytic cycling that we previously did not recognize. I've been talking a lot about some of the concerns in the literature. Well, this is a really nice finding that, if confirmed, suggests that interdialytic cycling should be included as a core component of comprehensive exercise interventions. I'll come back to this later, but interdialytic cycling in and of itself, probably not robust benefits that have been shown for a lot of outcomes, but this is a really unique finding that I think deserves special attention. So I'd like to take a minute just to briefly summarize the existing literature on exercise in hemodialysis patients, because it is kind of confusing. While most of the literature indeed shows some modest benefits, and I don't want to minimize that, but the data is flawed and, in my opinion, oftentimes uninspiring. And I keep bringing this up because I think it is important to acknowledge the limitations of the data so we don't continue to make the same mistakes we've been making for decades. Several recent trials have provided some intriguing benefits. The EXCITE trial I mentioned, improvements in physical function and one of the largest, longest interventions conducted to date. Cycle HD, another robust clinical trial of interdialytic cycling where you saw a reduction in left ventricular hypertrophy and improvement in arterial stiffness. And then there's these pilot studies. I showed one of them, but actually two different pilot studies that showed a reduction in myocardial stunning with acute interdialytic cycling that I think need to be replicated in some larger trials, but they are intriguing findings. But I do want to mention there's other recent robust trials that have not shown many benefits. I mentioned the PEDAL trial. There's a couple of other studies, one out of my lab, the Jiang study, that did not show improvements in physical function or cardiovascular related outcomes in response to interdialytic cycling. Another large trial out of Australia didn't see many benefits either. So the summary of these three trials is that there were no changes in physical function, arterial stiffness, and or quality of life from either interdialytic or out of clinic exercise. And we've got to acknowledge that the data is not as robust or impressive as we'd like to think it is. So my take-home message is that exercise in dialysis patients, hemodialysis patients, has many documented benefits, but there's a lot of caveats in the literature as well. And regardless of how one might interpret the scientific literature on exercise and dialysis, implementation of exercise programs in dialysis remains low. So we're not doing, there's something that we're not doing right. And so if we want to improve, we've got to figure out better ways of implementing exercise in dialysis patients. So the question I have is, how do we move forward? So one thing I want to make sure I emphasize is one consistent problem I've seen in exercise trials in dialysis patients, and that's the volume and intensity of exercise in most studies has been very low. Now, to be honest, most studies don't actually do a good job of measuring exercise volume and intensity, but here's 4 studies to highlight I've highlighted that did different types of exercise prescription. You can read about these on your own time if you like. What I like to focus here is on the calculated work rate in these different studies. Most of these were interdialytic cycling or walking, where the average energy expenditure, 35 calories per session, 35 to 80 calories per session. Here's another one, 73 calories per session. You're not getting these patients to move much during their workout program. So if the exercise is, you've got a really sick population, you're not prescribing a lot of exercise for them, what magnitude of benefits can we really expect to have? And this is a consistent problem in the dialysis literature. So with that in mind, on this slide, I'm saying this a little bit sarcastically, I guess, but I want to kind of highlight how most exercise programs are implemented in dialysis clinics. I like to joke around, there's sort of 4 primary steps. The first is that clinics will decide they want to run a program and they buy some relatively expensive bikes and they start to stick them in front of dialysis patients. A nurse, a technician, or a researcher will provide bikes to the patients 3 days a week and encourage the patients, beg the patients to pedal for about 30 minutes per session. And the participation in these programs are low. The enthusiasm for the program wanes after a certain amount of time, and there's a lot of patients dropping out. There's other patients who want to adhere to what you're asking them to do. And then the program ends. These expensive bikes that were purchased start collecting dust in a storage room. I think we can do better than this. And that's one of the reasons we're talking about this in this part of the course. So if I had my druthers, what should a modified exercise prescription look like for dialysis patients? I've been trying to make the point over and over again that what we have to do is move away from these structured, simplistic, exercise prescriptions such as interdialytic cycling, which is the primary form of exercise prescription, or doing simple resistance training, or just doing walking programs for our dialysis patients. And what we need to do instead is think outside of the box of how do we get these patients moving more by any means necessary. So my proposed alternative approach is shown on the right, where we really trying to develop programs to meet patients where they are. And that's using a combination of different types of activities, such as low intensity, what I call fun activities, whether it's walking the dog or grocery shopping, lifestyle activities that patients might enjoy doing more and they'll engage in more, and things we can progress them with. So we have low intensity fun activities. Interdialytic exercise is an important component for some patients of an exercise program. If we can get them moving during dialysis, whether it's on a bike or lifting weights, that's great. But also got to get them moving out of the clinic, whether it's low intensity fun activities or higher intensity exercise, such as going to the gym or lifting weights or doing recreational types of activities. The other thing we have to do, we've got to get the patient's family involved or caregivers involved. We've got to get the clinicians involved to help motivate the patients. We've also got to address other concerns. I talk about comprehensive lifestyle modification, and this is going to include nutritional modifications that are going to help get patients healthy enough to exercise. So how do we get there? How do we improve exercise programming for hemodialysis patients? A couple different things. First, I think we need to do a better job of assessing the patients and figuring out before they start an exercise program, are they ready to start one, or do they need some sort of prehabilitation to get them healthy enough to exercise? And this could involve a number of things: physical therapy, treatment for depression, nutritional management to get them healthy enough to exercise. Finding out what the patient wants to do or willing to do. We like to talk about meeting the patients where they are and giving the patients the autonomy to choose different types of activities that they're willing to do or able to do, as opposed to mandating structured exercise all the time. There's several groups around the world are moving this direction. There's some studies that are in progress to try to get patients moving more instead of just focusing on structured exercise. And we also know that progression of exercise is very important, but it's often ignored. So this is a very important training principle, and we need to make sure that we're advancing the patients through a program in an adequate fashion. Another thing we need to do is get the patient's family and friends involved. We know that the social aspects of exercise are critically important to maintaining their physical activity levels, and this is something we haven't done a really good job of in many studies. And lastly, I think it's important to try to do some things to change the culture at clinic. And I like to talk about this concept of inundating clinics in a culture of physical activity. And what I mean by that is making sure that the clinic is a place that supports physical activity, whether it's the nephrologist, the nurses, the social workers, or others at the clinic are welcoming to the concept of engaging patients in more physical activity. So I think if we do all these things, we're going to have much better outcomes from our trials, and exercise is going to be accepted much better than it is today. And with that, I'm going to finish up and pass it on for the next part of our presentation. Thank you for your time.
Welcome to Exercise in Peritoneal Dialysis Patients. I'm going to talk today about scarcity of exercise studies in peritoneal dialysis and highlights of selected studies and highlights from the peritoneal dialysis exercise guidelines that have recently been produced. So the question around why peritoneal dialysis, why exercise in peritoneal dialysis, I think is important because in a recent review in the Seminars in Dialysis, the authors argued that we had a particular issue around conservative medicine, and potentially, given the fact that patients have to be independent and have to be exercising when they're at home because they have to fundamentally do their own peritoneal dialysis. I think it's really important that we look at the physical activity in this group. We know that people in peritoneal dialysis or receiving peritoneal dialysis are actually inactive and highly sedentary, and that's measured by some step counts in some of the studies that are already being done. And you'll see that in these studies, mainly from Japan, is that most people who are receiving peritoneal dialysis on average have step counts around about 4,000, which is far below the 10,000 that are recommended by on a daily step count. I think one of the reasons that we are concerned and we do act a little conservatively is that we lack the knowledge and skill and scope of practice to actually expertly prescribe and coordinate optimal and personalised exercise programs. This is an issue because we fundamentally it's really difficult for us to be able to prescribe, given that we don't know. We're not exercise professionals. We're mainly dialysis and nephrology professionals. And there's been research in exercise. However, it's scarce. From 1998 to 2017, there's only 6 studies. Compare that to hundreds of studies in hemodialysis, mainly small and mainly with no controls. However, recently we've seen a couple of studies that have provided some really valuable information in this area. The first of the ones I want to talk about is Uchiyama's study from Japan, and certainly it showed from a randomized controlled trial some really encouraging signs when it comes to exercise. However, this has been the largest RCT with 47 patients. However, it's still fairly small. So these are still small trials. As we know, PD patients are potentially fairly tricky to get to do these studies. So what did they do? They basically did a home-based aerobic intervention over 3 months, and measured shuttle test, measured other measures of physical function. They showed that in a shuttle walking test, that in the control group did not increase, in fact decreased their score. However, in the exercise group, there was a better outcome. When these exercise group, the intervention group, were separated into high adherence and low adherence, we certainly saw an improvement in the high adherence group. When we tested their quadriceps strength, there was no change in the usual care, and there was an increase in both high adherence and low adherence groups. And in group strength, we saw a decrease in the usual care group and a decrease in the non-adherent group in the middle, but we saw an increase in the adherent group. So these are all signs that if people are adherent to an exercise program as a person who's on PD, then they will improve their physical function and not only their activity. What's really important, I think, is whether this can translate to clinical practice. So yes, we can show that physical activity can improve, but how do we get this actually into dialysis programs? We looked at this in a study, feasibility study, in one fairly large PD program in America, and we looked at the feasibility of an exercise program. So what we did is we had one exercise physiologist who basically worked 2 days a week out of a peritoneal dialysis home training program, and they set up a prescription and a program, and we basically stratified PD patients into 3 groups. And you'll probably recognise that these are quite fair when it comes to, and they reflect some of the PD patients that you have in your group. So we looked at low functioning, intermediate functioning, and high functioning, and we provided individualized prescriptions based on these prescriptions. And I think if you want to take something out of this talk, this is the slide that you take out of. Is that these are some of the exercises that have been trialed and have worked and are feasible for people on PD. So we did 3 months study. of this. And the most important things was how feasible, that was our aim, how feasible was it to have exercise programs in peritoneal dialysis programs. You can see from the top line, when we looked at eligibility, that in fact, 76% of patients were eligible for this study. However, we found that 73 out of 75, so almost 95% of patients in our program could be involved in an exercise program. We only 2 out of 75 were deemed medically ineligible. The others that weren't that didn't meet criteria were because they were not English speaking. That doesn't mean, of course, they can't exercise. 2 had amputations, and of course that doesn't mean they can't exercise. And even those unable to walk can still do some form of exercise. The 4 patients who had started less than 6 weeks, of course they would be able to start an exercise program once they sort of stabilised on dialysis, and they were potentially then eligible to participate. So out of those 57 who met the criteria, 2/3 of patients were happy to be involved in an exercise study and happy to do exercise, happy to be randomised into a control or a exercise group. Out of those 2/3, so remember we've got 2/3 of people who are on PD are actually happy to be involved in exercise. Out of those, at least 2/3 of those continued over a period of time and retained, and we maintained them in the study. And in fact, 2/3 of the adherence group, the majority of patients who signed up for the exercise program and were placed in the adherence group, in the intervention group, were continued and were highly adherent. There were no serious adverse events attributed to the exercise program. And importantly, when we asked the people who were in the intervention group whether any of them had continued, all of the patients had continued. So the same 10 that were adherent had continued to exercise 1 month after the study had finished, which was great. Although these were secondary outcomes and we weren't looking for changes in physical effects, what was interesting is we saw an improvement in all of our measures. However, these improvements were also in the control group. So remember, the intervention was having an exercise physiologist in the training centre. So clearly there were more people who were aware that exercise were important, and that filtered through to the staff and through to the other patients, and the patients even in the control group. So we saw an improvement in sit to stand, we saw an improvement in pinch strength tests, and we saw an improvement in 8-foot timed up and go test. And these are all measures of physical function and physical activity. What we did find, however, is that there wasn't anything really guiding us in physical activity. So there weren't any recommendations for peritoneal dialysis patients, and we felt that this was a gap in what we were able to do and what clinicians across the world could do. So what we did is we decided to get together with the Global Renal Exercise Group and the International Society of Peritoneal Dialysis to create the best clinical practice for physical activity and exercise in people undergoing peritoneal dialysis. This was a process that we did. We involved clinicians, we involved anyone who'd been involved in exercise with peritoneal dialysis patients, and we involved certainly patients who we started off the program and people who were receiving peritoneal dialysis, patient consumers, whatever we want to call that group of people who are patient experts with lived experience. They were able to contribute at each step of this guideline or recommendation process. What we looked at timing of physical activity, whether physical activity and catheter surgery around that. We don't want people doing ridiculously vigorous things straight after a TENCOF's been put in. We also looked at whether people should exercise when they're wet or dry. Specific activities that were important, such as swimming and water sports, contact sports, vigorous activity, core strength, work, sexual activity, those specific activities that people who are on peritoneal dialysis are particularly concerned about. Other concerns were potential infection related to activity, perspiration, activity for those people who had bad cardiovascular bad cardiovascular health, who are frail, who are fatigued, and some of the mental health aspects around activity. What's really important too is that you can't exercise without eating. And so importantly, although it wasn't a focus, which is nutrition, which is highly important in people with kidney disease, but we really focused on nutrition related to fitness and related to activity. So some of the dietary practice points around activity on people who are receiving peritoneal dialysis, some of the obesity aspects, given that there's a high glucose load for these people, and particularly most patients have a low baseline fitness level. So how do we incorporate nutrition and fitness into this? I'll take one example, and one particular example. I think that people, there's a lot of discussion around core strength for people with peritoneal dialysis, given they have a Tinkoff catheter in their tummy. So the question, we start off with a question from the perspective of the person living with peritoneal dialysis in these recommendations. So how do I safely strengthen and maintain the abdominal core muscles when I'm on PD? And the rationale for that is that weak core abdominal muscles may increase hernia risk and place an additional strain on the spine, particularly when accompanied with the PD fluid in the peritoneal dialysis space. And the rationale includes that potentially strengthening core muscles may further support PD dwell and potentially reduce the risk of catheter leaks and hernias. What's the evidence? So we looked through the evidence. We did a systematic literature review on each area, and this is only an example of one area of these recommendations. The randomized control trial that I mentioned previously found the intervention was well tolerated. There were no adverse effects. There were no leaks. There were no hernias. A 2019 study potentially suggested that increasing abdominal core strength may reduce the risk of inguinal umbilical hernia occurrence. Furthermore, the lowest intra-abdominal pressure occurs in the supine position, so that could be recommended for exercise, and strengthening abdominal muscles can protect and prevent back pain in PD patients, and that was all the way back in 1983. So we've known about this issue for a long time. So what do we do given the lack of really good randomized controlled trial or systematic meta-analysis supporting this? So our practice points suggested that core strengthening exercises are suggested for PD patients. Stronger core muscles can support the lower back and manage low back pain. And there's certainly some strong evidence that supports that. There's lesser evidence in the PD patients in that stronger transverse abdominal muscles can support intra-abdominal pressure secondary to PD fluid, potentially reducing hernia risk. However, we have no fantastic studies, no strong studies that support these. Clearly, we need further research here. So the further research questions that we look at are interventions to improve core strength safe. So are they feasible, and what are their effects? And what is the association of core strength with incidence of hernia, back pain, and catheter leaks in this group of people receiving peritoneal dialysis? So hopefully some of you can go out and research these sorts of questions. One of the other major areas, of course, in people with peritoneal dialysis with a catheter is around swimming and water sports. So again, we went through the same process, and our practice points are as such as swimming should preferably take place in either seawater or private swimming pools where possible. If swimming is in open water, avoid swimming directly after storms. The safety of other water sports, not swimming, such as water skiing, such as being in a spa, would relate to the location of these activities. And the fact that the PD and catheter exercise should be covered with either a clear waterproof dressing or colostomy bag has a little more strength. And the most important thing that with quite a bit of evidence is that routine exercise care should be performed after swimming or after water sports. The ultimate is, with all of these recommendations, is that we want people to live their normal life. So the ultimate objective is to try and assist someone like Rob to maintain his love of fishing in Northern Australia. So a summary of this talk is that physical activity and physical function can be poor in people receiving peritoneal dialysis, even though they have to lift boxes and do their own peritoneal dialysis treatment at home. Physical function and activity are vital for people receiving PD to maintain this independence in their treatment at home. And that exercise and activity research studies are far less in PD than hemodialysis and thus require addressing. The exercise guidelines examples that I've shown today have been produced on expert consensus, and these potentially can be valuable for clinicians and people providing PD. Thank you very much.
Hello, this is Dr. Mara McAdams DeMarco. Today I'll be talking about exercise for kidney transplant recipients. In this section, we'll define prehabilitation. We will look at prehabilitation for kidney transplant candidates. We'll review a prehabilitation pilot study, and then we'll close by talking about post-kidney transplant exercise interventions. To motivate this, I wanted to first focus on the high burden and consequences of impairments among kidney transplant candidates and recipients. Here in this figure, we looked at the risk of mortality among kidney transplant recipients who had a walking impairment at the time of admission for transplantation. By 3 years, we can see that the cumulative incidence of mortality is 7% for those who had no walking impairment and rises to 21% for those who have a walking impairment, which suggests that at the time of kidney transplant surgery, those who have walking impairments are at a 3-fold greater risk of mortality after 3 years after transplantation. And that motivated us to think about what types of interventions we could perform to help our patients prior to transplantation. We were most interested in the idea of prehabilitation. And the reason why was that surgery, in particular transplant surgery, is known to have an impact on and cause physiologic stress. This is almost comparable to an intense exercise. We can think of surgery as almost being the marathon for our patients. When patients undergo surgery, we know that it causes increased metabolism and catabolism, increased oxygen uptake, stress hormone production, and increased inflammation. So the idea here is to conduct a prehabilitation intervention that is like training for a surgery. You would never run a marathon without training beforehand. Interventions in prehabilitation seek to help a patient by enhancing their functional capacity so that they're prepared to tolerate the surgery stressor. It often includes an exercise component with strength, aerobics, and stretching components, but also can be multimodal and include nutrition or psychological components as well. The shift here is really from to optimize patients prior to surgery rather than try to fix the patients through rehabilitation afterwards. We've always thought of prehabilitation as being ideal for kidney transplant candidates. These candidates often have a long waiting periods for deceased donor or live donor kidney transplant. While the patients wait, we know that there is a profound loss of functional decline, including due to aging, due to frailty, due to comorbidity, and the underlying stress of undergoing dialysis. We think of prehabilitation as a way to possibly mitigate this loss of function while waiting for a kidney transplant. Early in our investigation of prehabilitation, we sought to gain consensus from physicians and patients about the need for prehabilitation among kidney transplant candidates. What we found were that physicians overwhelmingly were interested in prehabilitation, thought that it would make ESRD patients less frail, and would help ESRD patients after transplantation. While there was slightly less support from patients, overwhelmingly they were interested in prehabilitation and thought that it would help them and their frail colleagues as well. Therefore, we began a prehabilitation pilot for kidney transplant candidates. Our prehabilitation was designed around weekly physical therapy sessions that were all conducted at an outpatient rehabilitation center. The sessions were 40 minutes long and all overseen by a physical therapy assistant. There was an additional 20 minutes of supervised free exercise after the PT assistant care. It was conducted at our outpatient physical medicine and rehabilitation center. We sought to design this prehabilitation intervention with the goal of improving physical functioning and performing cardiovascular exercises, but we also allowed patients to target any specific current concerns that they believed they wanted fixed during the PT sessions. These often included things like improving their fall risk, improving lower back pain, and other types of activities. Participants were also asked to participate in at-home exercises between the prehabilitation sessions. In our pilot study, we were able to enroll 24 kidney transplant candidates in this weekly prehabilitation study. All patients were to be between 3 and 6 months of transplantation. We found that participants attended 12.6 sessions on average, and they had a mean age of 52, but we were able to enroll patients as young as 34 and as old as 72. Similar to the demographics at our transplant center, 72% were African American, 49% were female, 31% were frail, and 53% had lower extremity impairment. Now, I'd like to give a little bit of insight from the participants about prehabilitation before I get into the numbers. Here, we found that 100% of participants reported that they were very satisfied with prehabilitation. We also conducted a qualitative assessment of the feedback that we received from patients, and I've presented some representative quotes here. They all centered around themes of increased physical function and energy, sustained endurance, better weight control, and improved attitude. My favorite of all these quotes is that I sleep better, feel stronger, and have more endurance. It really shows the pleiotropic effects of prehabilitation for these kidney transplant candidates. In addition, we also gave our participants physical actigraphy monitors to count the number of steps that they were taking per day. And what we have here is a figure showing the average amount of physical activity counts per hour over the course of wear. We're going to focus first on the baseline, which is the blue line, and the red line, which is the physical activity counts at 1 month of prehabilitation. At this point, there is a 6% improvement in the amount of physical activity per hour. If we look, though, at 2 months after prehabilitation, what we see is that there is a significant improvement of 61% compared to before the prehabilitation intervention. Now, this was a pilot study, and we did have some limited evidence for the impact of prehabilitation on post-transplant outcomes. We had 5 candidates who received prehabilitation and also went on to undergo kidney transplantation during the study. We then matched them to age, sex, and race matched controls, and we found that those who were in the prehabilitation arm of the study had a shorter length of stay. And this was true when we compared the average length of stay, which was reduced from 10 days to 5 days, as well as when we used a Poisson model to show that the relative risk was reduced length of stay. Now, this is where we often start to think about when is the right timing to intervene for our kidney transplant candidates and recipients. Is it before, through prehabilitation, or after kidney transplantation, through rehabilitation? We found that transplant candidates may be more motivated to exercise knowing that they have this life-changing opportunity for this major surgery coming up in the next few months. We also believe that intervening through exercise post-transplantation may not be optimal because this patient population faces a steep decline in physical activity even within the first year of transplantation. It also has been found that there is poor adherence and poor compliance when patients are prescribed rehabilitation. If we look at the clinical trials, there are often very high dropout rates of transplant exercise interventions. Furthermore, many transplant patients have a prolonged recovery and are often rehospitalized within the early postoperative period, making the introduction of any new lifestyle changes very difficult to initiate and maintain. And for those who are lucky enough to have a relatively easy transition onto from dialysis onto transplantation. We know that this does allow these patients to return to work, to school, or other life activities, which also reduces the amount of available time for exercise. However, there are a few studies of post-transplant exercise interventions that are worth exploring today in this talk. The first four are relatively small trials that are of what you'll see varying durations and varying exercise activities and outcomes. However, all have been shown to have some impact on differing outcomes, including physical activity levels, total energy expenditure, pulse wave velocity, and bone mineral density. The two that I've highlighted here in green, I'd like to focus on because they have the longest follow-up, the highest number of patients, and have interesting facets that I think will make that will be influential to both pre-transplant rehabilitation as well as any future post-transplant rehabilitation exercises. So the first study was conducted by Roy et al. Here they're looking at aerobic training and resistance training. This was a year-long combination of these two interventions for kidney transplant recipients, and the study was able to enroll 85 participants. They compared the standard of care versus exercise training for 1 hour under a supervised training protocol 3 times per week. The exercises include stationary bike for aerobic training and low intensity and high intensity repetitions with the goal of increasing muscular endurance during resistance training. The exercise group experienced a significant increase in maximum workload, plantar flexor muscle strength, VO2 peak, and jump height, but also experienced a decrease in BMI of negative 0.5 kilograms per meter squared. The second study was home-based exercise interventions that was conducted by Serper and colleagues. This was a study of effectiveness of this home-based intervention rather than an in-center intervention. They focused on post-transplant weight gain and walking speed. Now, this study is a little different than the previous because it enrolled both kidney and liver transplant recipients, and they were all randomized to a 12-week monitoring period followed by a 4-week post-intervention follow-up. There was a control arm as well as an arm that received accelerometer alone, only an accelerometer and the accelerometer alone arm. Here they were given this wearable step tracking device, similar to what we used in our pilot study, and access to an online portal with resources for healthy living. The third arm of the trial was the intervention arm, in which they received both the information and accelerometer, as well as goals for the step numbers, coupled by financial incentives and healthy engagement questions to increase patient step counts by 15% from baseline every 2 weeks. In this study, they found that all groups' weights remained stable throughout the study. However, in this intervention arm, they found that there was more physical activity, and these patients were more likely to achieve over 7,000 steps per day when compared to the accelerometer alone group. And this was statistically significant in their logistic regression model. I'm intrigued by this study because it suggests that home-based exercise programs that have these behavioral incentives may be a way to improve physical activity, but may not be successful for weight control. Here, I'd like to summarize our findings. Here, the pre-transplant form, we believe that pre-transplantation is an ideal window to recruit patients into self-driven efforts and modify health behaviors such as exercise. And these will pay health dividends well into the future, as was described by my colleagues. But we found that only one study of kidney transplant candidates showed that prehabilitation impacts post-transplant outcomes, which means that there is a great need for future studies. Most of the studies that we identified were during the post-transplant intervention period, but the benefits of such interventions were still unclear. I'd like to end on an optimistic note, though, for the field of prehabilitation and post-transplant rehabilitation. For prehabilitation, I believe that there has to be additional research to focus on key remaining questions. We need to first identify what is the optimal transplant patient population to target. Is it our older patients? Is it our frail patients? Is it those who have lower extremity functional impairments? Then we need to define what is the standard prehabilitation regimen. If you saw for the rehabilitation, the definitions of physical activity and physical activity interventions varied across all the study, suggesting a real need in the field to define what is prehabilitation. We then must figure out what is the optimal duration of time to be enrolled in a prehabilitation intervention, and when should we do this in the course of waiting for transplantation. The final research priority is understanding the cost benefit of such a prehabilitation intervention. We recognize that this is going to be both labor and cost intensive for many transplant centers, but believe that with the appropriate studies, we could justify these costs against the long-term costs of physical impairment and graft loss and mortality among this population. The other incredibly important question that must be addressed by any larger trial is to determine whether prehabilitation both improves near-term pre-transplant outcomes, really priming patients and making them ready for transplantation, and whether there's a sustained benefit after transplantation that reduces these key outcomes after, including graft loss and mortality, particularly cardiovascular mortality in this population. Finally, we need to better understand what is the optimal post-transplant intervention to reduce weight gain and prevent cardiovascular morbidity and mortality. Again, this is cardiovascular morbidity and mortality leads to the highest number of deaths in this population. And so I'd like to summarize Module 3. Here we discussed that exercise across the spectrum of CKD and ESRD is safe and can be beneficial for most patients. We found that there is strong epidemiological evidence that individuals with CKD have better overall health and quality of life the more active they are. We did note that benefits in some clinical trials have been modest due to a variety of factors, including low exercise volume and intensity, and inherent challenges of working with patients with poor physical functioning. We also noted that the implementation of exercise programs in CKD have been challenging due to the lack of resources and training. And this course is one way that we are hoping to try to address this outstanding challenge. We also noted that clinicians need to encourage strategies to improve physical activity and function as part of the standard of care. We also noted that special considerations must be made to address physical limitations and other comorbidities that many CKD patients face. We also found that there is an outstanding need for ongoing and future studies that will hopefully address these issues. So please stay tuned in the future for more work in this field. Thank you for completing Module 3. Feel free to take a look at the module self-assessment to test your knowledge on our review of the overview of exercise in non-dialysis CKD and end-stage kidney disease. The next module you will see is screening needs assessment and outcomes testing. Thank you.
Take a moment to evaluate your knowledge with the following self-assessment questions. Feel free to pause the video at each question to identify the correct answer. The correct answers can be found on the GREC's website.